Welcome everyone. My name is Dr. Bill Gray from the Lankenau Heart Institute in Philadelphia, Pennsylvania. I'm here with Dr. George Adams and Dr. Pat Geraghty to talk about the TOBA II BTK trial data set. George?
So George Adams, interventional cardiologist, Rex Hospital, part of the University of North Carolina at Chapel Hill Health System.
Pat Geraghty, I'm a vascular surgeon at Barnes-Jewish Hospital with Washington University Medical School in St. Louis.
So guys, really interesting data. This trial investigated a second form of the Tack device. I'll let you talk about that in a second, specifically below the knee patients. And the results were pretty remarkable. And we'd like to talk about the ramifications of those results because I think they may have meaningful impact on practice. So George, can you tell us a little bit about the device?
Sure. So I think in terms of the trial, I think first of all, one of the things that it makes us think a little bit more about is dissections. Right, in the past, Bill, and I think Pat would agree with me, is that, we really hadn't put as much emphasis in dissections. We've always described dissections as either being flow limiting or non-flow limiting, but I think this trial brings awareness what type A and type B dissections actually has in terms of an impact in terms of patency and TLR. The second is, in terms of your question, the device. Now we have a device, a scaffold, that has been studied below the knee, in which we haven't had in the past. Typically it's just been plain old balloon angioplasty as our treatment of choice below the knee, which many of us have believed have been suboptimal but have not had any other devices to treat. But this 6mm scaffold, and there's 4 of them packed in one device, we now have the opportunity to tack up dissections and actually place a scaffold below the knee to hopefully improve outcomes.
And those device tacks, the 4 that are on the single delivery system, are ranging in size capability for between 1.5 and 4.5 millimeters, is that right?
That's right. So it's 6mm tack devices. They're 6 millimeters in length. You can treat from a 1.5 to a 4mm diameter vessel below the knee.
Pat, you've seen the results. We've talked about them fairly extensively. What's your couple of key takeaways? And George, be prepared, I'm going to ask you the same thing, from the global results.
Well, I think it really is going to augment an aggressive approach to BTK disease. We have been missing that critical piece of scaffolding beyond the niche use of off-label coronary stents in the very proximal segments of the tibial vessels. And I think the results of this are excellent. We're seeing patency rates in 87% at 6 months that are just superb. And so that allows us to, I think, more aggressively size angioplasty to the tibial vessels. I think the tibial interventions suffer from chronic undersizing. So to get better luminal gain, to pursue more aggressive recanalization techniques that may result in some dissection flaps with the knowledge that we can then restore patency and tack up those flaps appropriately. So I think this will really increase our overall level of aggressiveness in treating tibial disease.
I agree. I think that it opens up a lot of doors for more enthusiastic approaches, knowing that you have a solution for dissection. George, this trial was unique in a couple of different ways, not just in the design of the device, but also in the trial methodology. Can you touch on that for a little bit?
So in terms of the trial methodology, I think the most important thing is this is probably the first trial that enrolled 100% of dissections. So every one of the patients treated had a dissection. So that's first. The second, this is, I guess, the first trial looking at using a scaffold below the knee.
And therefore, it might be the first implant available on label.
Definitely, yeah. No question about it. Right. And for the success, especially in these critical ischemic patients, it's very important.
Touch on the wound healing and 6-month outcomes on the clinical side, Pat, if you would, for the audience.
Yeah. I think in this, as in some of the other BTK trials that are coming out, we're seeing a nice improvement. We're seeing excellent hemodynamics, a sustained improvement in toe pressures out to 6 months. We're seeing substantial healing of wounds, but not complete healing. And I think there's a little more of a deep dive to be done into the effects of neuropathy and diabetes in terms of persistent or recurrent wounds. But what we're not seeing is these majority of Rutherford 5 patients translating into major amputations. Our major amputation rate was extremely low over the first 6 months of the trial. So I'm very pleased that overall I think we're achieving the requisite level of perfusion to the foot to prevent progression to major amputation.
So the correlation between toe brachial seems to have translated into a clinical benefit, which is great. George, you work a lot in the SFA. I know you do a lot of critical limb as well, but contrast for us a little bit the differences between the requirements of tools in the SFA, the challenges below the knee, where we fall short, and where this might come into play a little bit.
Great. So I think above the knee compared to below the knee, first is the tools. We have a whole array of tools to treat above the knee, especially scaffolds, whether it be self-expanding or balloon expandable stents, for example. Below the knee, we have very little. This, as you have mentioned just a second ago, this is probably going to be the first implant that will be granted the opportunity to treat below the knee. So that's first. The second thing, in terms of above the knee and below the knee, the vessels are smaller. Right? A lot of these have chronic total occlusions. Recoil and restenosis is very prevalent in this population. So giving us the opportunity to keep a vessel open longer below the knee, especially in a person who has a wound, is beneficial in hopefully healing that wound.
This trial does not stand alone. It actually comes after 3 or 4 different trials, mostly above the knee, all above the knee. A pivotal trial that we presented last year, TOBA II, where SFA patencies were shown to be at least as good or better in a more complex lesion set. And for POBA, that was for DCB, and for POBA, remarkably better compared to historical controls, up to almost 90% at 1 year. So now we have this trial. We have these data with remarkable primary patencies of around 90%. What does this tell us about the assumptions we made on benign dissections? Pat?
Well, I think it's a really interesting story if we look all the way back to like the Viva OPC, what we thought balloon angioplasty in the SFA would be, which was high 30%. And then we come to the IDE, the POBA arms of the IDE trials for drug-coated balloons, and we see that they were actually achieving 50-60% at 1 year. And now we see that TAC-optimized angioplasty has elevated that even further. And likewise, we're seeing, plain balloon angioplasty performing well in the below-the-knee trials for drug-coated where it's been randomized. And we see in the single-arm trial that it appears to elevate those results again. And granted, this is a lateral comparison. We're not randomized, but it's really provocative and intriguing to me. I think this implies that there was more to be had out of treating dissections than we conventionally believed. We had the NHLBI scoring system. We always treated something that created absolutely sluggish flow. But the question is, when we were leaving behind flaps that were modest in nature, that didn't appear grossly flow limiting, what was the clinical outcome? I think the single arm results here are provocative and make you question whether or not we should have had a more aggressive approach to those in the past, and certainly looking at these clinical outcomes would make me take a more aggressive approach now.
Yeah, I think that it's hard to walk away from these data and not come to that conclusion, right? If we think back, I've been around long enough that I remember when those NHLBI classifications were developed. I think Steve Ellis developed them, and they really were meant to assess the acute outcome, securing the vessel patency and so on. They weren't really meant in any meaningful way to talk about long-term patency. The Japanese data a couple of years ago suggested that actually patency was linked to dissection, and I think that was an observational study without any mechanistic, plausibility. Now we have a mechanistic application of a technology which seems to validate what we otherwise considered benign from an acuity standpoint, but from a long-term patency standpoint was probably meaningful. And I don't know, George, if you have thoughts about whether or not that has to do with flow or diameter or all of the usual stuff that we talk about for patency.
Yeah, and I think a functional assessment of flow I think is very important, and maybe that's the reason why. Again, a lot of times we just get a 2-dimensional angiogram. We don't get that 3-dimensional view. So our flow may be actually worse than what we're expecting in this 2-dimensional angiogram. Yeah. And the other thing that's interesting, and I think Pat brought it up earlier, was the toe brachial indices in this trial, and it actually sort of tracked. You had an improvement in that toe brachial indices, indicative of the primary patency and the low TLRs.
It's early days. The data are still fresh. We're still digesting them. I don't think any of us have really played with it enough to know how it fits into our practice flow. But blue sky, how do you think this fits into the CLI paradigm in terms of the? I mean, I'll ask you, Pat, from a surgical versus endovascular perspective. Does it elevate one or the other? Does it change that perspective, or just from an endovascular perspective? I'll ask you that, George, and Pat. What do you think this does for how we think about below-the-knee disease?
I can take a first shot at it. So I don't think it would necessarily change the equation for me as to when I think surgical bypass is indicated, but I think when I look at endovascular therapy, it's going to augment it. It's going to be a life preserver. It's going to allow us to be more aggressive in terms of luminal gain, more aggressive in recanalization, and I think it's going to make our below-the-knee practice look more like our above-the-knee practice in terms of our willingness to take on complex lesions. It doesn't mean as a surgeon I abandon surgical therapy altogether, but I think for those patients that I'm addressing with endovascular therapy, it's something that I'm going to be thankful to have around in terms of a scaffold.
I mean, to extend Pat's comments a bit, and I agree, I think it's interesting today we do have off-label stents for, most of us would use it really in the proximal 1/3, but in this trial, that's not where all these tacks went. There's a fair distribution.
Yeah, it was all over, Bill. It was impressive. I mean, typically we stay away from the distal third, whether it be because of the ligaments, concern of crush, smaller vessels. But in actuality, at least a third of the tacks placed were placed in the distal third, which is interesting. The other thing is just to add on to what Pat says, with critical limb ischemic patients, these are tougher patients. These are chronic total occlusions we're trying to cross. With the advent of the tack, we're now able to be more aggressive in understanding that we now have a treatment option if we supposedly get in trouble. Say we were to go subintimal, for example. Now it gives us an option to successfully tack this vessel up.
Yeah, I mean, the idea that we could, have a loop and a wire and go subintimal almost to the ankle and have a bailout that we never really had before, I think is going to make, as you said, to your point, Pat, going to make us more willing to be aggressive, hopefully lead to more successes because of that more aggressive stance and an available bailout. So it's important, I think.
I have a hard time not seeing this rapidly become a component of best clinical practices for distal endovascular interventions.
Well, I want to thank George and Pat for their comments and really for your excellent work in the trial. You've been terrific PIs, represent the data well and the device well. So we thank you for that. We look forward to more discussion around the TOBA II BTK results coming soon. Thank you.